Okay, now let's have a look at how the thorax moves to allow us to breathe or respire. So respiration or breathing can be broken up into two phases. The first phase is inspiration, which is where we breathe in. And this is all about drawing air into our lungs. And this occurs by increasing the dimensions of the thorax to increase the thoracic volume, which will decrease the pressure within the thorax, and that will cause air to rush into the lungs and to fill. And this phase of breathing is dependent on the action of muscles. Now, when we're just quietly breathing, most of that is due to the action of the thoracic diaphragm. However, there are accessory muscles of respiration which also help with quiet breathing and then become even more involved when we have to breathe deeply. The second phase of respiration is expiration or breathing out. And this is air passing out of the lungs, and this is due to a decrease in the thoracic volume, increasing the pressure within the lungs and forcing the air out. And expiration can occur in one of two different ways. When we're just quietly breathing, it's a passive process, so it's not actually using any energy. And this is just due to the elastic recoil of the diaphragm and the lungs. However, when we're breathing heavily, which is called forced respiration, it's an active process. And we recruit the action of various muscles, accessory muscles of respiration, to help reduce the size of the thorax to force the air out of our lungs. So we'll start off by looking at the diaphragm, and then we'll look at the movements of the ribs and the accessory muscles of respiration. So the diaphragm lines the entire inferior surface of the thorax. And the diaphragm will form two lobes, and in the middle of each lobe will be a central tendon, and the muscles will be around the fringe of that central tendon, attaching to the ribs, to the vertebrae, to the sternum. It's also worth pointing out that sitting anteriorly and kind of in the middle, in the mediastinum, we have our pericardium, which are those serous membranes. And passing through the diaphragm, we have three major structures. We have the inferior vena cava, delivering blood from down in the abdominal cavity back up towards the heart. We have the esophagus, taking food down towards our abdomen and our stomach. And we have our descending aorta, which is delivering blood to the lower half of our body. In this diagram, we can also see the parietal pleura and the cut edge of the parietal pleura where it's been peeled back off of the diaphragm. This is going to line the entirety of the diaphragm and the thoracic walls. And we can see a costodiaphragmatic recess, so between the ribs and the diaphragm. And under normal conditions, this is just a potential space. There's no lung tissue within this recess. It allows an extra bit of space for the lungs to expand into when we breathe in deeply. Now, viewing the diaphragm from underneath, we can see the different parts of the diaphragm. We can see that there's part of the thoracic diaphragm originating from the sternum, so this is the sternal part. We have parts originating from the ribs. These are the costal origins. Then we have a right costal part and a left costal part, and then we have the lumbar part attaching to the lumbar vertebrae. And we can now see the openings through the diaphragm. We have the caval opening for the inferior vena cava, we have the esophageal hiatus for the esophagus to pass through, and we have the aortic hiatus for the aorta to pass through. Now, the thoracic diaphragm is firmly anchored to the lumbar vertebrae. And so muscle fibres from the left-hand side arch over the aortic hiatus to form the right crus to attach to the right-hand side of the lumbar vertebral bodies. And muscle fibres from the right part of the diaphragm will arch over the aorta and form the left crus, which will attach onto the left side of the lumbar vertebral bodies. And arching all the way over the aortic hiatus, we have a median arcuate ligament. If we look at all of this from side on, when we look at the opening through the diaphragm, so we have the diaphragm here, we can see the inferior vena cava passing through the top of the dome of the diaphragm. So it's at about the level of the 8th thoracic vertebrae. We then have the esophagus coming through a bit more posterior, and so it's at a lower level. It's at about the level of T10. And then the aorta is running along the vertebral bodies, and so isn't passing through the diaphragm until basically the diaphragm is attaching to the vertebrae. And this is about the level of the 12th thoracic vertebra. So the IVC goes through at T8, esophagus at T10, aorta at T12. So the thoracic diaphragm at rest is domed up like this. However, when the diaphragm contracts, the diaphragm will end up flattening out, and so that is going to draw the lungs downwards and increase the volume of the thorax and allow air to rush into the lungs. Now, the bulk of the diaphragm is innervated by the phrenic nerve, and the phrenic nerve is originating from up in the cervical region. So, handy little mnemonic is that C3, 4, 5 keep the diaphragm alive. And this occurs because the diaphragm starts its development up in the cervical region and becomes lower and lower and lower as the embryo develops, and dragging with it the phrenic nerve all the way down. Now, the outer fringes of the diaphragm are also receiving some innervation from the lower intercostal nerves as well. So the phrenic nerve is predominantly involuntary, so it just works away without us having to think about it. However, when we breathe deeply, say we've gone for a big run, the outer fringes of diaphragm will be innervated by those lower intercostal nerves. They will help those parts of the diaphragm to contract so that we can breathe deeper. So you can read more about the muscles of respiration by consulting your prescribed textbook, the study guide, and your principles document. This is Dr. Lloyd White. Thank you very much.